All right, everyone, for the sake of time, we'll go ahead and get started. Good morning, everyone, or afternoon, depending on where you are. My name is Larry Ozawara, VP of Care Delivery at Mantra Health, and I'm excited to be hosting this webinar today. Our talk is called Why Mental Health Equity is Critical for Student Success, and I'm honored to have a conversation with three truly exceptional leaders in the field who will discuss the ways in which institutions can meet the needs of diverse student populations. Just a few housekeeping items. I'll introduce our speakers who will be leading our discussion today, and then I will basically sit back and let the magic happen. The discussion itself should be about an hour or so, and then at the end, we'll open it up for questions. But feel free to drop any questions you might have in the chat at any time. Apparently, we already received over 100 questions so far, and we haven't even started. So we're excited to answer as many questions as we can. Last thing, just for the sake of discussion and to keep things conversational, you might hear us using first names, which we agreed upon prior to the talk. All right, so let's begin with a round of introductions. First up, I have Dr. Shantae Albert. Shantae recently held the position of Associate Vice President of Health and Wellbeing at The Ohio State University and currently holds the role of Chief Health Equity Officer for Columbus Public Health, where she leads the team for the Center for Public Health Innovation. She's a trailblazing figure in the realm of college health and wellness, having dedicated 18 years of her life to the betterment of student well-being and success. Shantae, do you want to share with us your positionality?
Absolutely. Thank you, Larry. Hi, everyone. I am a 40-year-old gender Black woman, a proud first-generation college student who has earned 3 degrees comprising of a bachelor's, master's, and educational doctorate. Alongside my academic journey, I've navigated the difficult path of surviving anxiety, depression, postpartum depression, and ADHD. In addition, I navigate life as a mom with children with hidden disabilities. Rooted in this legacy of being a child from a teenage mother and a father consumed by the crack epidemic, I have survived, and I am still surviving trauma. Yet I am sustained by the resilience passed down to me by my ancestors, and I do this work with purpose, ministry, and passion. My multifaceted identities and experiences infuse every facet of my work. Thank you, Larry.
All right, thank you. Next up, I have Dr. Swapna Hingwe. Swapna currently serves as the Associate Director of CAPS and the Director of Psychiatry at Michigan State University. She also serves as a campus coach for the Equity and Mental Health on Campus initiative supported by the Steve Fund. Her work centers around mental health equity for historically marginalized student populations on campus, integrative and intersectional psychiatry, and eating disorders. She specializes in working with students of color, international students, and LGBTQIA plus students. Swapna, do you want to share with us your positionality?
Yes, thank you. Good afternoon. Thank you, Larry. My name is Swapna Hingwe. My pronouns are she, her, hers. I am a cisgender, physically able-bodied woman. I am of South Asian descent. So specifically, I'm Indian. I'm the child of immigrants, the first person in my family born in the United States. And my parents came here to go to school. So they came here from India to go to school. What else do I want to tell you? I struggle with some chronic invisible disabilities. I've been married for 18 years. I'm a mother of 2. And again, a parent to someone with some invisible disabilities. And I'm a therapist and a psychiatrist, and I think that's everything that I want to share. So thanks for having me.
All right, thank you. Last, I'd like to introduce Dr. Sheree Watkins. Sheree currently serves as the Associate Vice President of Student Health and Wellness at the esteemed University of Utah. She is a distinguished clinical psychotherapist, certified coach, and expert in the field of mental health and wellness. Her expertise encompasses public health, mental health, rehabilitation, and substance use counseling, and she is dedicated to transforming systems that hinder marginalized populations from accessing crucial counseling and addiction services. She's also Shantae's twin. Sheree, do you want to share with us your positionality?
Thank you, Larry. Good morning, everyone. I am a 40-year-old cisgender female Probably also a first generation college student along with Shantae. And as you also heard, we are proud descendants of a teenage single mother, also descendants of the crack epidemic from my father. So we are survivors. I'm also a survivor of sexual assault. Unfortunately, that 1 in 3 college students. And I'm currently on my own journey of recovery, and which I'm very proud of it. I am a mother of a child of 2 children with hidden disabilities, and also have a lovely challenge of living this life with my own hidden disabilities of lupus and also ADHD and also postpartum depression. And so it's definitely a navigation that when we live daily, one day at a time. So really in this legacy, I definitely believe in living what my ancestors have given me as being a Black woman from this conceptual model of historical trauma, which is that I am innately indebted with resiliency as being a strong Black woman. And so I have multifaceted identities. And with that, I strongly believe that this is my purpose, passion, and ministry in doing this work holistically. And thank you, Larry.
Thank you. All right, we have completed our round of introductions. To kick things off, Shantae, could you give us all some context on why we're here and help us understand what mental health equity is and its role in higher education?
I'm going to try to do it in a very short, targeted amount of time. But yes, I think this conversation is long overdue. So I'm very grateful for the STEAM Fund and Montreal for bringing us together. But I think we're really facing what I've started to call a population level storm happening across our country. But not just with our students, but we're seeing a level of workplace absenteeism and productivity challenges happening. We're seeing school-based absenteeism and academic performance issues from K through 12, often also within post-secondary education. And so right now, this is an all hands on deck situation. I think there's no one area to really start to address the needs when it comes to mental health and wellness. And so what has really been happening in previous conversations has been a really targeted conversation on just counseling, and more so counseling centers in higher education. And for those who've heard me on my stepping stool, this crisis that has been talking and kind of really tokenized has really left out a lot in some of these white papers and articles that we've seen in some of the higher education papers, because they left out quite a few things. That one, some of the turnover, some of the challenges facing in hiring is happening in all the other departments that support mental health and wellness across our campuses. And so to not look at all of that from a very multifaceted, holistic view, we can't talk about mental health from an equity-based lens. And so that has been a really, really big challenge. And so talking about mental health equity, I think we have to take a huge step back and look at how emotional, psychological, and social well-being are the premise and basis of mental health. But we also need to look at mental wellness too. And then when we do that, we can now look at it from an equity lens. And we start to address how the populations that we serve, and we look at the places that they live, work, play, and worship, and how they are able to thrive or sometimes just survive. We look at their race, their ethnicities. We look at their service and access to languages and the barriers that they face. Then we can start to address equity from that lens. But in higher education, that is a challenge, because if we're looking at it only from the counseling center lens, we're not able to look at it from a holistic point of view. And that's why we're here today, because we need to look at it from an equity-based lens. And in my current role as a Chief Health Equity Officer, my role now is looking at it from a very population level work, from policy to capacity building to looking at the education and community engagement. And so that's why I'm happy to be part of this team now, having a larger, more equitable conversation about how we can now transition some of this work back to higher ed and look at it not just for our students' success, but for the faculty, staff, and employees doing this amazing work and to meet their diverse needs on campus. And so that's how I wanted to kind of lead us into this larger conversation around how do we can reduce the stigma and how we can expand the conversation from just mental health and wellness to looking at it mental health equity. So from there, I really want to turn it over to Swapna and have a larger conversation on what does mental health equity look like on our campuses and what can it entail.
Thank you. And as you were speaking, I was I was reflecting a little bit on how I got involved in the Steve Fund and this type of work. So, and I'm glad you brought up the fact that, you know, for so long, the onus of taking care of these kinds of issues, mental health issues, is always on counseling staff or psychiatrists in my case. And so what I started recognizing probably a while ago, but I think put a name to about 3 or 4 years ago, was that I was doing a lot of really intentional work on mental health equity in my office, and then sending students out onto campus where they would potentially have harmful racialized experiences, and wouldn't be doing as well as they were when they were safely within my office. And so that, I think that idea that our students really need holistic approaches for mental health equity, I think that's kind of what I want to talk about a little bit here. So what does this work entail? It's a huge question, right? So mental health challenges, we know they're prevalent among students, but we also know that certain student groups face additional barriers in accessing effective care and resources. And so when we're thinking about how to create an inclusive and supportive environment for students, all students who can thrive academically, emotionally, and mentally, we know that we can't just center our advocacy efforts at a counseling center or at a mental health clinic on campus. And so if we're taking into account historically marginalized students on our campuses and thinking about how to create opportunities for those students, how to build that community, how to rebuild some communities, because I think at some of our institutions, it's a question of building and rebuilding. And then how to foster communication and collaboration between all the campus partners. So that's it. That's all you have to do. So that's how I think about this when I think about mental health equity work. It has to encompass all of those pieces. So for me, working as a psychiatrist it's a Big Ten, it's a predominantly white institution. I really, I would say that what was a really important experience for me was to start writing this book chapter about the actual needs for students of color on predominantly white institution campuses. And so, and this was just recently that I did this and wrote this chapter for a psychiatry textbook. And in writing that chapter and looking at how our students of color and students of color with intersecting identities, how they access care, how they stay in care, what's important to them. In writing that chapter, I started really looking at the work I do, whether it's in my office or on campus, with an equity lens. So what do I mean by that? And I won't share all the things that I try to consider, but I think it's really important that when we think about all of these student groups, we're thinking about how are we developing welcoming spaces for them? How are we involving students and with their lived experience? Because I think so often institutions and universities are really well-meaning and well-intentioned with programs, but they're not considering students' lived experiences and what they need. So I always try to think about that when I'm planning something, whether it's around an issue or an activity. And another important question is just, how do intersecting identities impact how students are going to experience a particular issue on our campus or a particular event or activity on our campus? So that's just a little bit about me and why I do this work and why I think mental health equity work is important and what it means for me. I do want to just really quickly share that I'm here representing the Steve Fund, and I'll talk a little bit more as we go about what the Steve Fund programs look like. But I got involved with the Steve Fund in 2020. And the Steve Fund is a national nonprofit organization that is devoted to the emotional well-being and mental health of students of color on college campuses. High schools also considering graduating college students going into the workforce. And Shantae kind of, really talked about how it's not just this college experience, it's everything leading up and then everything after. And so the Steve Fund really focuses on centering the voices of students of color. And so they have a flagship program, maybe flagship's not the right word, but they have this really amazing program that really is a way for universities to partner and talk about systemic change. And it's called the Equity in Mental Health Framework and the Equity in Mental Health Campus Initiative. And so I'll talk a little bit more about that as we go. And there's some resources that you'll have later that are about the Steve Fund. But I think, again, we're talking about holistic approaches for students who come from multiple marginalized backgrounds. And I'll stop there because we have lots more to talk about. So I'm going to stop and turn it over to Sheree. And what I want to ask you is, how is this work changing and evolving on campuses?
Thank you, Swapna. There's a evolution that's currently happening on our campuses, and there's a movement and a push, even as you look at some of the Q&A questions and some of the resources that people are already sharing. But some of the main premises that we're seeing is this innovation of the use of technology and also innovative resources and tools and services. But if you look, it's linked directly to the very end pieces. Where is this technology and innovation stemming from? It's stemming from research and evaluation through data. We're using our data to drive how we're creating inclusive approaches and services and resources. And how are we doing this? We're going back all the way to what Swapna have been talking about, Shantae has actually been talking about, by being inclusive in our approaches, but also looking at it from a population health standpoint, and not just, in my infamous terms, being firefighters. We're not constantly just putting out fires one by one as they're occurring on our college campuses. So, for example, when we're talking about the use of technology, just the use of Mantra, and all these innovative different types of online apps and resources to once again be inclusive. Many of our college campuses, whether they're in cities, rural approaches, are not able to meet the needs of our very diverse student populations. Number one, it's hard sometimes to recruit diverse clinical professionals, and that's inclusive of all different types of clinical professionals that we may need to serve our diverse student bodies. It's hard to recruit them to these very rural populations. I'm in Utah. It's even hard to recruit diverse clinicians, medical professionals, wellness professionals, in these very diverse apps, whether it is wellness coaching or even counseling or psychology or psychiatry, and also diverse languages, provides resources and services for our students to be able to receive clinical services from people that they identify with. And we know that can once again be very resourceful and equitable, so they can receive the best services and also have better outcomes in the end. But also with the use of this technology, we have to go back to something that's going to be very innovative. We also have to go back upstream when we're looking at prevention, using technology in a very different and innovative way. One big thing that both me and Shantae have talked about is, in order to do population health well, we need to know our students before they step foot onto our campus. By the time they step foot onto our campus, we are already behind the grain. We already are not able to help our students to navigate our healthcare system. And that is, once again, how do we once again be inclusive? What we have on our campus is a healthcare system. And that is something that we have not been able to navigate in the use of this term. We have always seen ourselves as being siloed, but we need to start being transformative in saying that we are a healthcare system for our students. And how do we look at that as being transformative is that in healthcare systems, we navigate, we have comprehensive care. And whether you want to call it comprehensive, integrative, a culture of care, they're essentially all the same terms. And so in this innovation, we have seen this greater awareness over the last couple of years. And so we have the apps, we have the technology, we have this greater awareness. But with that, we haven't seen the diversity of the resources and services begin to also expand with that. We now have wellness coaching apps. We have a little bit more groups. We have a little bit more counseling, different types of innovation. But I have not seen the diversity of our types of services begin to expand too. I have not seen spiritual resources expand on our campuses because that's a part of the wellness wheel. I have not seen the expansion of different types of treatment services that is upstream for prevention to be expanded on our college and university campuses. And I have not seen the expansion of policy changes. How are we helping support mental health and wellness and health services for our students when it comes to how we plan, do campus planning, policy changes, leaves of absences, returning to campuses. And so all that happens with inclusive and comprehensive approaches. And so I ask this question: what does our case management programs on our campuses look like? Where do they sit? Is it segregated or is it centralized? There's pros and cons to different types of models, and I'm not here to sit there and say one is better than the other, but is it coordinated? And then the infamous question: how many different types of EHR systems, different types of advocate systems are, systems that's once again documenting different types of information? Are they talking to each other? And then most importantly, if we're using going back to that term of saying that we are a healthcare system, how do we refer our students in this healthcare system if we have 3, 4, 5 different systems? Because one question that I ask myself, if I want to send a student from the Center for Disability Access and I want to send them to my Center for Recreation Services for Movement is Medicine, how do I refer them from that department to this department? And they say, well, what is movement is medicine? Well, I know movement is just as beneficial as medication, as counseling, as coaching. I want this program developed. And we're not thinking comprehensively. And so the last point that I make before I want to go to another question for us to consider is, are you using your data correctly? Are you using your data to drive your approaches, your technology, how it's effectively used? And most importantly, when you're getting your data, are you disaggregating it with the specialized and historically marginalized populations on your campus? The new NCHA data just came out, and it's very upfront that our LGBTQIA populations are not being historically serviced continually on our campuses within our health and wellness realms. What does that look like in comparison to your campuses? How do we use that to advocate? Because one of the major questions is to advocate to the C-suite. How do we actively apply and create services for the populations on our campus? We need to be data-driven and not just evidence-based. So I asked Shantae, what does mental health equity work entail for institutions? And this is a good transition. And what should we actually be focused on? Is the question that I want to pose to you.
Thank you. And I see some questions are already coming into the Q&A in addition to the ones that were submitted, and we will add those to our list for when we start to wrap up. And so Larry and the team are already adding those and trying to put those into queue. So thank you. Keep adding those to the Q&A and we will work through those. And so when I think about what campuses should be focusing on, I think I have to acknowledge the elephant that's on the screen that's invisible. I'm fully aware, I'm only 2 months out from my higher ed journey, that the resources are limited. And at some of you all's campuses, they're almost non-existent. And only when crisis happens do sometimes that helps move the needle. It is what it is. And that's unfortunate. So how do we center mental health equity, mental wellness, and well-being collectively, and to be focused on things? And I think, Sheree, you focused on something about using data to inform us, and that all best practices may not help us with this conversation around mental health equity. A lot of the research that could help us with our students who represent historically minoritized, marginalized backgrounds, the data and the research may not be there, specifically for your population that's on your campus. So we may have to be informed and use more of practices, promising practices versus best practices. And I often think about some of the conversations I've had with colleagues over the years that submitted for grants on research proposals that were not approved because they didn't have the data to justify it. And they were specifically for students of color. And so I want to emphasize that if we're going to do health equity work, sometimes the data doesn't justify the why. And so you have to make sure that if you're going to focus on health equity, you use your students and your faculty and staff and that data, which may be more qualitative or anecdotal, to justify your why. And that could be making sure you retain them, because having a diverse campus when it comes to faculty, staff, and students is a best practice. Difference in thought, difference in what you have on your campus is best for having students, faculty, and staff who are able to be global citizens. And we know that research has already been proven. And so when I think about having an approach that can help our campuses, I think some of this work now will involve collaboration and partnerships that evolve off campus also. So now that I'm off campus, if you're not working with your local health department and your nonprofits that's doing some of the work around prevention and treatment, then you should. Many of the health departments have now been able to get workforce development grants and been able to get grants thanks to some of the allotments made by the federal government to expand and retain prevention staff and also staff within the health department is clinical because there has been a lot of turnover in public health. So they have seen the same thing we're seeing in higher ed. They also have been seeing it too. That's why I think it's so interesting that in higher ed, we focus so much just on counseling when public health has been focusing on the entire workforce. And I think that's important for us to focus on and use collaboration and partnerships, because those workforce development grants are $1 million grants that they focused on retaining the entire public health team that is a multidisciplinary team that can possibly fill some of the gaps that our campuses can't fill. I think also when I look at collaboration and partnerships, those grants are also focusing on expanding professional development and cultural competency. If you all can't bring that expertise to campus, partnering with them and other nonprofits will allow you all to do maybe a comprehensive approach to professional development and training. And so I think we have to get very strategic and very creative and innovative on how we approach expanding our mental health equity work on our campuses. And that will help us do diverse outreach and support for our populations, because that referral process will get easier when we know who we're referring them to. When you know who you're doing a smooth handoff to, it's a lot easier when you're in space, in place with them on a consistent basis. And more importantly, trying to reduce stigma has to be comprehensive, not just the walls within our campuses, but also the comprehensive town gown experience. And I know it's been challenging for many of our campuses because we are lean and mean when it comes to staffing, but we have to figure out what our focuses will be around well-being. And that way we can be very strategic on how we want to approach mental health equity and health equity overall. And so Dr. Watkins, Sheree already mentioned, how do you want to use some of the apps and vendors? Because that may be your best approach at the moment when there's no more resources coming in. And so I think that has been some of the things that I focused on, but don't be afraid to try something new. Some campuses have done well with some of the peer-to-peer support, some of the peer-to-peer coaching, which we know has already been researched and tried and true and is a best practice. And so looking at how you can build policy and practices around things that will work for your campus. Equity doesn't say what's going to work at SWAPNA's campus may work at your campus. You may have to try something, tweak it a little bit, and see what's going to work. And I think that's how you figure out what to focus on. If you have the data, use that to inform you. If not, then start having some very focused conversations with your campus community to help determine how you want to navigate it. And so with that, I think it's kind of now to kind of look at things at a more systemic level. So Sheree, I'm going to kind of turn it back over to you and tell us why institutions should be taking a very systemic level approach and how they can do some of this work around health equity and more so mental health equity.
Thank you, Shantae. What we know is that individuals' well-being is deeply interconnected with various aspects of pretty much what we call the larger educational environment when we look at our institutional policies, social structures, and cultural norms. And then most importantly, we know that our students are not one-dimensional beings. We know that our students are multidimensional, they're not one-dimensional. And so when we're looking at creating mental health equity, we have to do it systemically. And so it means reducing the silos and looking at the identifying the root causes. Because, for example, one of my I was just talking with my AVP over student inclusion and diversity, and working with our office of in all the offices that fall up under him, which is our affinity and identity departments and divisions, which is that we're looking at working with my Department of Disability and Access and looking at, we already have embedded mental health counselors within our different identity centers. But now we're looking at some of our current data and with having individual conversations with some of these different students. I said, we now need to start looking at, with the use of the data, and a possible embedding of a disability advisor in our CSB main hub. So our CSB hub is the cultural center that once again holds all of our different identity centers, because we're seeing more mental health issues with our students who are of color and also our LGBTQIA, and they feel more comfortable receiving their services within their identity spaces. And so if we already have mental health counselors there, we should embed a disability advisor there so that way they can receive their accommodations, whether they have a physical or a hidden disability within those centers. And so again, it goes back to a term that we like to use, which is looking at the root cause, or what we call in the South root work, because it is a systemic approach of looking at what is truly contributing to student success, what is hindering from being successful in the classroom. It's looking at, once again, those causations such as stress, anxiety, but sometimes it may be that chronic disease or that hidden disability. And how do we once again embed or help students to navigate within these different departments? And so we need to invest resources into these different students' areas. But most importantly, we, for those of us who work in the student affairs arena, need to go across the bridge and partner and collaborate with our partners on the academic affairs side. I, since coming into this role, have worked continuously and meet monthly with our Center for Teaching Excellence. I meet at least twice a semester with our academic deans and our chairs to see what is the current pulse that we're seeing in our classroom with our students, because we need to look at it from a systemic level. The social ecological model looks at not just the individual level, but from a systemic level. And so we need to understand, once again, looking at it from the root, to understand not just doing what we call leaf and branch work, which is very easy of saying we just going to do a quick fix here, but getting to the root of how do we create systemic and long-lasting change. And one of those pieces of long-lasting change that we're also looking here is looking at providing health literacy to our students. How do we once again help them to navigate here on this campus? But when they graduate, do they understand what a copay is and what is co-insurance and those types of things? And so, in looking at some things that you can do on your campus, what does systemic work look on your campus, whether you are a small campus or even a larger campus? So next, in talking with, and I'll turn it to either Swapna or Shantae, what does a systemic approach look like to either one of you all, from Swapna, from your current approach on your current campus, and if Shantae, if you want to add in anything else too.
I can share a little bit more about the Steve Fund, because I will share that the Steve Fund's Equity in Mental Health, the framework, there are 13 recommendations about how to implement a systemic approach to mental health equity on your campus. So there are these 13 recommendations. And then what happens if you decide to work with the Steve Fund as an institution, you partner with them. There are researchers who do a needs assessment of your institution, because as we've been talking about, everyone's institutions are so different in their mental health equity journeys. Institutions can be different from one year to the next in their mental health equity journeys. So I think implementing some type of systemic approach that's looking at key recommendations for your university or your college or whatever your institution is, looking at that and then following through with action planning. And so what I heard both of you, Sheree and Shantae, I think you were both talking about promising practices. And actually that's what we talk about a lot in the Steve Fund when we're doing a lot of our cohort work, is promising practices and sharing out of promising practices. So I just want to tell you a little bit about how this program has worked. So in 2020, I had this idea at the height of COVID, that we should partner with the Steve Fund and start working on actually doing this equity and mental health framework. So I will share that at the time, we partnered with Steve Fund. They did a very thorough needs assessment. So they look at your institution's quantitative and qualitative data. They're looking at campus racial narratives. They're looking at archival information, doing interviews with student focus groups and with staff and faculty. And then they do this very comprehensive needs assessment for your college or university. And the Steve Fund works with Big Tens, with community colleges, with HBCUs. I mean, just across the board, wide variety of institutions. And so there are these 13 recommendations, but it's not that every recommendation is one that you can work on at your institution. And so what happened at Michigan State University was that, yes, it was the height of COVID. And we put together a team of folks who are going to work on this systemically. And I think one of the biggest things that I learned was that the silos, and I'm looking at this slide with reducing silos, the silos at our institution, and it's a massive institution. So it's a Big Ten, it's 50,000 plus students. It's enormous. And I would say every week I'm still discovering something new about the university. And so back in 2020, when we were trying to put this team together, some of the things that happened were, it was hard to understand how to get stakeholder support. And it was also hard to understand how we were going to share out information. And so with our needs assessment, we did ultimately end up sharing that needs assessment and doing some action planning with our chief diversity officer, with student life and engagement. And so the work has carried on into 2021, 22, 23, but it looks very different from how it looked in 2020. But that's okay, because that's the sustainable piece of this, is that when you are implementing a systemic approach, it's really important to make sure that that sustainability piece is there, and that you're involving stakeholders, that you're making sure that you're continuing the work that you began. And it's iterative, it's going to look different year to year, but really, really important. So I want to see if maybe we're going to shift a little bit. It looks like, yep, we're going to talk a little bit about community engagement. And so I'm looking at the chat and realizing that, I don't know, Shantae, was there anything you wanted to add to what I was talking about with the systemic approach?
The only thing I was going to add to the systemic approach was as far as the community engagement is actually one key component, which is acknowledging the steps that go with it, of really reflecting and strategizing. And this is one of the ways that within a more population level work of the kind of 9 steps of how you can do community engagement and do some of this work. But one of the things before you start to do step 1, I think that you have to do is acknowledge the past. I really think anytime you start to do anything to address systemic and structural racism or anything that has been systemic that are structural that's impacted communities that have been historically minoritized, under-resourced, underserved, just really acknowledge the things that have brought that to the table. And on our campuses, I think oftentimes it's happening in very indiscreet ways. Like we are recruiting students from inner cities and bringing them to our campuses without acknowledging the trauma that they are experiencing before they come to our campuses and think all of a sudden now they're a student, they're going to forget everything they've experienced up until they came to our campuses. And so before we can even start to reflect and strategize and identify and engage the stakeholders, which are the students themselves, I think we need to acknowledge, as Sheree said earlier, what has impacted them prior to coming. And so we should have already engaged in the community with some of the leaders within that community to see what has impacted those students and figure out what has worked because something has worked, so now they're coming to our campus, and work with those community leaders to make sure their transition from home to our campus continues to be well-rounded and they continue to thrive on our campuses. It's not enough to just bring them to our campus. I think it's quite unethical to bring them to our campus and then nothing further actually happens beyond, hey, now you are name your campus mascot. So I think that when you start looking at things from a very systemic and structural place, you need to honor the history of what has happened. You know, it's not enough to just have your statement on your website, on your Culture Center website. It's not enough to just say, you know, before every program, let's just say our statement. Statements mean nothing. It's the action that goes behind it. And so oftentimes when we sit down with these students and they start to say, you know, we've said a lot. We've heard the campus say a lot. But what we haven't seen is follow through. So I think before you start to engage in systemic work, the campus has to really take an inventory of, are we just going to bring together a working group to start this conversation, and then everything just dissipates when it starts to get to the implementation phase? Or will we actually follow through from the ideology to the program planning, implementation, and the evaluation phase, where we're consistently talking to the stakeholders, involving the stakeholders, updating the stakeholders through a very transparent way, that we are about the business of centering them, and that we're not just about bringing them to our spaces and not centering that their needs may be different from what we have been used to offering to them. And so I think for me, what has been hard is that we've seen these students come and then we wonder why they leave. And you didn't do the work on the front end. So that has been a challenge for me. And so I know, Swapna, you can dive a little bit deeper on what it's been like at MSU. I just shared some of my experiences in higher ed, but I think that's been pretty consistent for me if you want to share more about what has happened at Michigan.
So I will share a lot of the same frustrations that you were just referring to right now. And I can see I can see on your face as you're talking about it. Yeah, a lot of, because we bring these vulnerable students to our campus, and then what? And then what? What do we do? And so what I want to say is that, you know, at Michigan State University, there's a lot of history There's a lot of painful history. And I think in the last 3 or 4 years, we've made some major changes. And some of that, I don't want to say that it's all due to the Steve Fund. It's not, but I think that there are so many people on campus attempting to do systemic work, and not talking to each other. And so I think that's one of the biggest things I realized, participating with the Steve Fund framework. And now I work as a coach, because each of the teams has a coach through the Steve Fund. And so now I coach a different university. And my experience, leading our Michigan State University team really informs how I coach. And I think if I can just share a little bit of hopefulness, at least about my institution, our senior vice president here has supported this inclusive campus initiative on our campus that actually really follows a lot of the Steve Fund framework. And I don't think that was intentional. I think it's just, that's the work. And so we have been part of this initiative for the last couple of years, the whole campus, and it pulls together stakeholders from across campus, pulls together community members, and really centers student voices, which is, again, what the Steve Fund is also really promoting. I also think, I listened to the two of you, Shantae and Sheree, and I think that what was missing for our institution was a health and well-being umbrella, which we now have. And it's relatively new still. We've only had it since November, but we have just an incredible gift in Dr. Travis. And I don't know if either of you knows Dr. Alexis Travis. So she is now our head of university health and well-being. And so what's happened just in the last few months is all these things we're talking about, pulling all of these different units together under one umbrella. And it's very exciting. It's a lot of change, but it's very exciting to see what the potential is there when you have that public health emphasis and background, which we haven't had at MSU. And so I'll stop because I could go on and on, but it's very exciting to see that mental health and trauma services, disability services, EAP, it can all come together and work in a public health model. And it's new for us, but I think that's a promising practice. So I'm going to stop. I'm not sure if I'm supposed to turn it over to Shantae or Sheree or Larry. I got really excited and lost track.
Happy to turn it over to whoever has any final things. We have about 10 minutes left, so I want to be mindful of time. But if there are additional things that people want to go over, let's go through those now, and then we can try to summarize at the end. I could sort of summarize some of the things that I heard. I haven't had a chance to speak a lot on these topics, but I got really excited and started jotting down some notes kind of in real time. So one of the phrases that I really liked was, I think from Shantae, justify your why, is what I've learned over and over and over in different institutions, both in the academic sector, private hospital sector, and in digital health. A lot of times in terms of getting somebody to understand or listen, you have to have a very convincing case as to why something different is better than the status quo. And I think that applies to equity and mental health as well. Some of the things that I learned, take an inventory, do a needs assessment, tackle equity at a systemic, not just a clinic level. Even thinking through things prior to students coming to campus, and all the factors that kind of go into what success looks like for each individual student. And then really working on an implementation plan, even using the Steve Fund 13 recommendations for systemic implementation. I think that's a great takeaway and resource that I was not aware of until very recently. And then know that there's no right way to do things, and that figuring out ways to meet the needs of the individual student population at your campus is absolutely critical. I can share just a little bit. I realized that I wanted to give everyone a chance to share their positionality. I did not do that for myself. I can tell a little bit about my background. Um, I'm a gay Black male psychiatrist. I came out during college, so university mental health is definitely like important in a lot of ways because that's where people kind of show up in their true selves. Complicating that, not only being like the first generation of Nigerian immigrants coming out as gay, being on a Division I wrestling team, all of those things were a little bit complicated, as you might imagine. And despite being a psychology major, even just figuring out ways to navigate, mental health care in a college campus is really difficult, right? And so I never did. I ended up just kind of moving through and going on to medical, et cetera. But I wish I would have known the resources that are available. And I wish they would have been resources that really tailor to what I needed at that time. So I think all of those things are super important. I'm really glad that you were all doing excellent work in this field because it would have been nice if we all had that like, 20 years ago, right? Okay, let's see. Anyone else want to add any last minute takeaways before we open it up to questions?
I think the only thing I would add that we didn't get to talk about is to address some of the need to reduce the stigma is the marketing and communications. Mm-hmm. And many of our campuses have a very umbrella-ish approach to marketing and communications, but there is a whole degree called health communications. And these folks are amazing. And they have specialized training to do exactly what we need them to do. And if your campus can't hire specialized marketing and communications folks, then I highly suggest that you work with them to make sure that they understand the differences in marketing and communication for health communication. Now, I think some of them picked up on it for COVID, but when it comes to start addressing marketing and communications around health equity, you can be off the mark and actually cause more harm than good. And so I think it is very important as you embark on this work that you are very mindful of having a very comprehensive team of people part of the planning team as you do this work. That includes marketing and communication, because oftentimes some of the biggest reasons why there's a lack of utilization from your diverse student body is because they don't know you exist. And that could be because what you are using to do outreach and engagement via marketing channels and things like that are not reaching your diverse student populations. And so we didn't get to go deep into that, but I know it has been a hot topic over the years of let's have a centralized marketing communications team for student affairs. That has pros and cons. And with the cons is the timeliness of being able to get things done and the lack of having expertise of people who actually have a health communications background. And then the last piece is cultivating safe spaces for these students. Because of a lot of the legislation that is coming down the pipeline, the need to be very innovative and creative on how you do that is going to be necessary. But if you're going to recruit them, you still have to find a way to do this work. And I see that it's going to be a challenge on how to do that. And my best way to approach this, I know in higher ed, we have consistently separated areas such as student affairs and academic affairs. We have also separated DEI and health and well-being. But you cannot do anything around student success unless you start to center equity with DEI and health and well-being. They are all one and the same. And so I just had an opportunity on Monday to present around student success. And one of the speakers right after me is a national expert in student success and equity. And I sat and watched her amazing presentation. And it only backs what I'm saying now, which is student success, which means retention, butts in seats, and why students fell out is highly tied to the social determinants of health, also known as the basic needs. And if you don't know what's impacting your student population, and you haven't addressed them from a holistic point of view, or you're now trying to ask your academic advisors to become health and wellness coaches versus partnering with your health promotion team or your recreation staff, you are approaching it again from a very siloed lens. Your academic advisors don't need anything extra to do with their very heavy caseload. Your DEI team needs to work with your multicultural team, your LGBTQ staff need to work with your health and wellness staff. That's your clinical and your prevention team. If you all want to see this work move from beyond what it has done since the beginning of our work in higher ed, you need to start looking at this work out of how we have traditionally in higher ed set our departments up. So find a way to start bridging the gaps between these departments. Then you will start to see a better return on your investment, and you will start to see a better engagement, a higher sense of belonging from your students. Hashtag TM Dr. Elbert.
Yeah, that's a tough act to follow. Thank you for that. I mean, yeah, nailed it. We do have lots of questions coming in. The first one is to Dr. Watkins, but anybody can answer. So, Sheree, can you elaborate on evidence-based versus data-driven research? How do you get leadership on board with this thought process when they are evidence-based focused?
Start with the first part. The major difference between evidence-based and data-driven. Evidence-based, in very simple terms, is who was at the table, who determined that it was evidence-based. Typically, it is a rigorous process of research to determine if it has been evidence-based. That means that research has been conducted I'm going to use simple language, multiple times by various different entities, and the research has been validated by these multiple different entities to say that we have gotten the exact same results over and over again. And now we all can conclusively say that this research with this particular tool, idea, or whatever it may be, now is the gold standard and should be replicated among this population or this populations, and it is now termed to be evidence-based. However, typically who determines that is a group of people around the table who is conducting that research. And in the past, the people who have been around that table has not looked like anyone sitting around this Zoom, especially when it has come to health and wellness. And then we also can look at that when we have looked at historical medical research. And so that by itself also secondly validates and verifies why that is also a concern with when we're looking at health and wellness. Data driven, that definition is saying that we're going to take some data that we have collected for our population of students, and we're going to look and see what does the data, and I'm just going to use an example to keep it simple, what does the data say about the alcohol usage of our students on this campus. In the past, we have said that we're going to take all this data of alcohol and we're going to mark it between no use, mild use, moderate use, high use, binge use. And we're going to just say that this is the data that we're going to use. What we are now saying is that we can do that as a whole, but we also now need to look at historically marginalized populations, LGBTQIA populations, and even within LGBTQIA, we need to look at those who may be trans, and then also break it down with our higher risk populations within LGBTQIA too, because now we're seeing through data that, especially with the recent NCHA data, that those who are trans, their numbers are looking drastically different for mental health, chronic health, and also ATOD. Go look at it. It's the executive report. And so then we also need to look at our students with disability, because when we're starting to look at and break down all that data, it's called disaggregation. the data may show us something different. And when we're looking at gold standard programming for alcohol use on college campuses, some of the gold standard usage, such as harm reduction, 12-step programming, smart recovery, any type of prevention, some of those programs do not work for historically marginalized and or BIPOC populations. They may need to be tweaked or not done at all. For example, Shantae mentioned that there was a project that was not given a grant when working with alcohol, tobacco, and other drugs. This is not our story. We're just going to repeat the story from our colleagues at HBCUs. They wrote a grant to do, what was the grant, Shantae? Was it hip hop battle?
They wanted to do ciphers. They wanted to do ciphers to help elevate the conversation. Yeah.
Rap battles. Okay.
Rap battles.
Yeah. And within that, they would do different types of outreach of talking with the students while they're doing the rap ciphers, the rap battles. So they would have music going on. They will also possibly do some testing, all types of things, because that would draw the students in. They was told that that type of programming wasn't evidence-based. But if you was looking at what was currently going on in society, ciphers was a big thing. You can go on YouTube, you can go watch the BET Awards, you can go watch even the MTV Awards, and it was a big thing. So they wasn't moving with the times. So data-driven means that we're using the data of what's currently going on with our campus to lead us to making our decisions on what type of programs, resources, and services that we're going to offer on our campus. And we're going to use, look at what may be some best practices, but we may need to modify it, which can totally turn that type of program to not be exactly like it, which will once again completely modify it. Or we may need to call a colleague across the street and say, hey, I need our data showing that our Hispanic population or our indigenous population. So you may need to call an HSI. Or once again, another campus that once again is not your expertise to say what is working on your campus, because this is a population that we may not be expert in, and we're having a problem with this population of students.
That's great. I think evidence-based usually comes from very sterile, best case scenario conditions that are just not relevant or practical. And so I think the data-driven approach adds that, like, the here and the now, the practical aspect of it, which can take you a lot further in a lot of situations. One question that came up, which I want to know myself, is you are all very passionate in the work that you do. So how do you all deal with the fatigue, the work, and getting decision makers on board? Or do you deal with it?
Well, it is very frustrating.
Mm-hmm.
Tears, lots of curse words, strong circle of friends and partners, finding ways to bring in those outside of my circle. So not just student affairs, finding faculty, finding those in administration who are strong partners and believe in this work, because we can't do this alone. And more so, when you find other first generation, other colleagues who are passionate about giving students an opportunity to thrive, that is your end. And they may not even be, it may not even be their lived experience, but you will find others who are passionate about giving students opportunities. And so it's easier when you start to find those wins. And then, now this is my stop out. I had to find a way to do this work from the outside in. And it's very beneficial for me to find a way to be you all's voice, a little bit louder, a little bit more straight no chaser, as you can see, because you all need a voice that is more direct on what's impacting you all. And that way you don't have to keep being firefighters. And so you all can have a voice who's done the work with you all, and now can come from the outside in and help you all navigate some of the challenges, because now I get to see it from the community lens of what's coming to your campus. And I also get to see what happens after they leave your campus. So I get to now look at it from a very well-rounded point of view. And so you got to have your own way of navigating it from basic self-care to self-comfort. So the self-care can be the hair, nails, makeup, general things, and the comfort is finding your own therapist, finding a way to process it when it's not fair. When you see the student who didn't get the support that they needed, or they needed $500 just to stay in school, and there was no way you all can get it done. And so it's hard. And so, but I also know that if no one else does it, somebody has to.
Yeah. Well said.
Larry, if I could just, I want to add a little bit to that, because I think about this all the time, about the fatigue. And I'm looking at this screen. I think one of the things that happens a lot on campuses is that folks of color are doing this work all the time, in addition to their regular jobs. And so I think that's something that leads to a lot of burnout. And I think what I've had to do over the years is try to understand that I have my personal agency. I have a community, a compassionate community, and I've had to develop those relationships and find those people. And when you find some of those people, sometimes they can say to you, "Hey, you need to tap out because you need a rest." And I'm going to take over with this particular project. And so I think it's having compassion for yourself, but it's also being part of a compassionate community. And it takes work, and it's long. This is like, it's marathon work, and I am not a runner. So it's you have to pause, and you have to be patient. And some of the work we do, we won't, we know this, we won't see the outcomes in our lifetimes, but we just keep doing it. And then we keep taking breaks and then getting back in. So yeah, I guess that's what I'd want to share.
Yeah. I think that's definitely true. I think self-care, having support, whether that's professional support, collegial support, outside support, and just having that camaraderie, I think can go a long way. And just knowing when to say when. I think that's something that we all probably need to work on, part of our natures. But yeah, I think that's really important as well. One question that came up is, what degrees or specific courses would any of you recommend in terms of just getting more knowledgeable on this topic? Or people, I imagine a lot of us just kind of learned it as we went and that kind of thing, but
So I don't have a public health background. I mean, I have a very clinical background. But what I have done over the last few years is try to read up as much as I can on public health and public policy, but then also doing a lot of racial trauma informed leadership training and just racial trauma training. And I don't think this is in the resources, but I think that understanding your identity and how it impacts the work that you do I think that's crucial to doing this and sustaining it. So I think it's not a specific degree, but I do think that racial trauma training, whether it's clinical or non-clinical, it's really important for us to consider and do.
I would agree with what Swapna just said also, because I don't think it's a particular degree. I think population health or public health or health education gives us that lens to understand how the public intersects when it comes to health and wellness, and also the medical system as a whole. But I think really some education that you can do is really just starting out with the term health equity as the larger term, because up under health equity will fall mental health equity. Really understanding what health equity is will give you the very first wave of understanding how that impacts access, treatment outcomes, and the basic understanding of how that also will intersect with also different populations. And then it will also give you even a stronger link to looking at historical trauma, as Swapnan also linked to, because health equity breaks it down from a historical lens and gives you the backdrop and brings you forward. And we'll take you even to looking at how even access to people of color with chronic pain treatment. So health equity is just very big, broad term, and will lead you down a very big tunnel of looking at all these different types of diseases, and but really looking at why do various different populations, and even looking at it from a socioeconomic lens and not just racial lens, of why do certain populations lack successful outcomes and mortality issues, birth rate issues, all these different types of terms. And so health equity is such this very large premise that it just deals with multiple populations, multiple issues when it comes to just looking at mortality within the U.S. and also quality of life.
And this actually, one of the trainings that I went through last year is actually one of the questions that was asked. I went through a training through the International Institute for Restorative Practices, and hands down, it was probably one of the most profound trainings I've ever experienced. Very rarely do I go through a training that puts the knot in my throat to this day, as you all just saw. And I think if you all could bring that to your campus to start working on what healing could look like as a campus, that is a huge step toward the right direction for you all to do health equity work. And so I know somebody asked earlier, how do you use restorative practices around health equity? They blend very, very well. There's a lot of research through the AMA around restorative practices, around in health equity, including how to do it from an indigenous lens so you can be culturally inclusive. There is so much work being done. So yes, there is room at that table to include restorative practices in these conversations, especially if you're doing it from if you're at a junior college or a community college and you're working with communities that have a unfortunate school to prison pipeline. I think there's so much work that can be done and from a restorative justice, restorative practice lens. And so the IRRP is one of the ones that I have went through, and I know there's others, but I am a huge fan of using, as my sister would say, use your whole entire tool belt to look at what is available for doing this work. There's no one way to do it. And so I just believe in being a lifelong learner and sitting at the seat and the feet of my colleagues who are experts in this work too.
Great. One sort of controversial question that came up is, can anyone address the July article from Inside Higher Ed about outsourcing therapy to tech-based solutions isn't ideal because often they do not know the specific issues of college student mental health? I will take a stab at this for reasons that people already know. So I obviously work in digital health. I am a VP at a digital health company that focuses on college mental health. So everything I say, just take with a grain of salt and actually ask somebody who has worked with a third-party vendor to get their own take, right? What I would say is this, digital health cannot replace counseling centers. Do not tell my boss I said that, nor do we actually take that approach. What I would say is, I'm just being a little bit facetious here, but what I would say is this, digital health can supplement college mental health, because with any college mental health, you have only so much room and only so many counselors, and you can't begin to just fulfill the needs of every single student who comes through your doors. And there are always going to be students who, no matter how wide your doors are open, will just not come into an actual office setting and want to just do it a different way. So I think digital health with third-party vendors serves a purpose, but it has to be done thoughtfully and it has to be done very well. What it can offer is additional opportunities to engage with a provider who's a better fit. Not that those providers are better or worse, but that they're just different options, right? And so you're providing access to a broader array of providers that I think can be really helpful and an asset to campuses. That being said, I think the providers or the vendors that you're working with really have to understand college mental health and what that looks like. And they also have to be able to understand the needs of that particular campus. So if you're going to work with a third party vendor, what I would do, I would give you a little bit of advice, which is know kind of who they are, what they stand for, how they're selecting their providers, what their providers look like, how they practice, and do they get college mental health? I think there's a difference between providing options, which I think a lot of third party vendors can do pretty easily. They can get people seen very quickly, versus providing quality care that's actually going to help the students. I think that's a separate and probably better question. I don't know if any of you have.
I've Yes, I have not at Ohio State, but I did a whole RFP process at my previous institution prior to OSU. And as Sheree mentioned, recruiting diverse, multilingual, multiracial, multi-ethnic therapists, psychiatrists, psychologists to the middle of nowhere is quite challenging. And one of the things we put in the RFP was all of those things of having the quality staff who could meet that need that we couldn't get to that state. And so there is a need for D, all the above. To sit here and say that having technology is unnecessary was the same thing they said about telehealth and teletherapy decades ago. I think it is, let me choose a different word that came to mind. It is not nice. That's my mommy voice right now. It is not nice for us to sit here and say, with broad strokes, it is not needed because they don't know college health. Well, I mean, look at us. We're on Zoom. They said we would never do Zoom meetings, and here we are. They said we would never walk on the moon. Here we are. I think for us to not use technology, shame on us. When I think about rural health, when I think about serving populations, aging populations, shame on us for not using what we have access to and being innovative. Shame on us. So for us to sit here and again use these articles to cause harm without doing our due diligence, I need for the people who keep putting these articles out to, one, have diverse people writing the articles. They are not people of color, so let me put that out there. Two, can you be more inclusive? Stop focusing on just counseling. The lack of representation, the lack of budgeting outside of counseling has not happened. I have consistently seen turnover in every other area. We still have peer educators as the only health promotion folks on some campuses, but they do the Title IX, they do the information around basics, they do the things around bystander intervention, but that's federally mandated. What sense does that make that we will have students who do 4 weeks of training, do all of that, federally mandated, but we pay students to sit at a desk at the union? But we're going to have people write articles because they're mad about a mantra and a time EMD. I think we need to make it make sense to me because that math ain't mathing. I think if we're going to use the time, use the energy, let's focus. Let's work with these companies to do what we need to serve our students. Let's work with them instead of putting them on the outside. I think when we don't know what we don't know, we just push them to the outside. We did the same thing years before. But I also want to take it from a different perspective. We didn't do it for the crack epidemic. Now we had to do it for the opioid epidemic. We have done the same thing for different settings and for different issues. I am not here for it this time. And I think we've done it consistently when it comes to things we don't know and we don't like. But I need for us to be, I'm just going to call a spade a spade. I need for my colleagues who are not of color to do right by this situation this time and include people who are at the table, who are of color, who are using this to support the students of color who don't have people who look like them and sound like them, where Mantra, Townley, Christie Campus Health are stepping up to fill the gaps. That's what equity looks like.
I needed to mute myself. Thank you. Yes.
I just want to say ditto, because I remember when me and Shantae were peer health educators, sliding condoms up our arm on the yard, doing HIV testing. I remember when the first wave of two movements happened when we were in undergrad and graduate school. The first wave was they were talking about moving us up under the rec. And I said, that doesn't make any sense. Why are y'all moving health education and promotion up under recreation? Like they didn't make any sense to us. But then it happened right after we left undergrad. And, I didn't hear anybody at that time in the health and wellness realm say anything when there was this big, massive movement of moving health education and promotion up under rec, and our identity was lost. I didn't hear anything when many of our health and wellness centers were wiped out right after that. I didn't hear any advocates for my counseling centers then. And so just to kind of put the nail in the coffin, I just need for us to be consistent in how we advocate for health and wellness services across the board. Because I've even said it to my counseling director here, don't ask me for no money. When I got my disability advisors, it's one advisor to 450 students. And right now there's a waiting list for my students. Currently in this semester, there's appointments up until September 15th, which is an issue. And that I had to think about possibly asking them to come in on a Saturday to make sure we get accommodations made so we won't be pushed out into fall break.
Oh.
Because you have to look at your counterparts.
And COVID increased the amount of disabilities. So again, it's an ethical concern.
Yeah. One question that came up was, how do you incorporate health equity to offer services in an institution that has essentially all white staff, for example?
Health equity, it definitely deals with, of course, racial issues. But as you heard me mention, it's not just about race. Health equity deals with gender, socioeconomic status, physical and hidden disabilities. And I can give examples for each. When we're talking about right now, death and dying for labor and delivery of mothers of color, that's an example. But when we talk about those who are less likely to seek access for healthcare, period, it's not just a racial issue, it's also a socioeconomic issue. If you fall below the poverty line of any color, you're more likely to have a higher mortality rate. And so you're going to die earlier compared to any other. And so then we start to look at other issues. So we're looking at all issues of healthcare and all different types of, when we look at that demographic portion of those surveys, all of those questions can lead to health equity issues. So yes, race is a portion of it, but don't forget our students and ourselves are intersectional. We are not just one beings. I am a Black woman with a hidden disability. So even our counterparts who are not people of color are once again living with their own health equity issues. And so we can look at health equity from how do we service our students who are not of color, who may be dealing with intersectional issues that are health equity issues. And so we have to look at it that health equity is all issues. And then there may be some intersectional issues dealing with race, gender, and sexuality that may be different from their own identity, that they may need some additional help and or training with. But we always can start with just the basic of how is health and health outcomes different for all people that is serviced in the U.S. How is it different from the age, the life expectancy? Just start off with that. What's the life expectancy in the U.S. for different ages and different races in the U.S.? And just start with that basic question. Let that be a part of maybe the icebreaker for your next meeting. That can be a good opening question to, let's talk about health equity. What's the life expectancy across the U.S. for all races and genders? Why is that important for us?
But think about students, thinking about staff. I think about, since COVID was a good question coming up, what population had to quit their jobs the most because of COVID? Parents. Then caregivers. So there was no, the consensus was some of our lowest income. But then we started seeing then all the people who were considered frontline. And some campuses don't have anybody of color. So that was just anybody who's a frontline staff. the daycare shuttered. And so, when you start looking at some of our campuses, there was no racial barrier. It was who was the lowest paid on staff, who was being impacted by COVID disproportionately. Now, we know in some areas that was people of color, but in certain communities where there was a low end of people of color, it was your lowest paid, your lowest socioeconomic status. Then it was parents, those who were caregivers. So when you start looking at things based off access to care, those in rural areas who didn't have access to anything, those who stay in food deserts, you can start looking at things from that perspective. High school graduation rates, education. And so, those are things that we can start looking at when people have a hard time talking about race and ethnicity. So it's easy to have that conversation, but I always, when I have this conversation with people who are non-melanated, my first question is, if we want to make sure we replace ourselves, we got to make sure they get to the table.
And I just want to throw in here that even if it is an institution that has a center with all white staff, our job when we're looking at health equity, no matter what our racial makeup, is that we have to be aware of the structural inequities, and we have to question our own biases. And then we have to understand that part of our role, and I really firmly believe this about mental health clinicians, but I think this is true just across the board at universities, part of our role is to intervene on behalf of our clients and our students and our patients, and to advocate for their health equity. That is just part of what we do. So I don't think it matters at all if it's an all-white staff or what the makeup of the staff is. Everyone has to do the work for it to be sustained.
Oh, the one time I caught myself on mute. Okay. One thing that I wanted to kind of add to that is we have we all have bosses, right? And we have to get people to buy in. So any thoughts on how to embed mental health equity into the campus strategic plan, or how do you get administrative buy-in? What has been your experience? What have you learned so that we don't have to repeat the same things?
Shantae said it. You want to just do repeat? Put yourself on repeat, Shantae.
Below it's dollars and cents.
Dollars and cents.
And if you find a way to, most of the time I have learned that they don't know why students don't re-enroll, because they just don't enroll. So that's the first thing. And then when they find out the survey is so broad, they just click health. Mm-hmm. And so that's the first thing. Let's look at your process and your policies. And let's look at how do you now follow up with those students who stop out. Mm-hmm. And how do you recruit them back? And so I think our processes don't help us in figuring out how do we center health equity in this. And then if it's dealing with mental health, how do we center mental health equity? Because I think mental health equity could be our students who stop out because of they've had a mental health crisis. It also could be when they have an eating disorder and they need to go to treatment, and now they may be coming back to campus through eating disorder treatment team. So it's a couple of things that can help with that. But when you can start saying, if we put these things in place, the butts can stay in the seat. Yeah. And so when your enrollment management team is making their plan and none of your service providers are at the table, that is also a gap. So when they have an enrollment management plan to increase the population by 500 students, and as Sheree talked about, there's already a waiting list, but you find out after the students are there, that was the plan 6 years ago. That's also what's been happening in higher ed. There's a disconnect between the enrollment side and the service side. Mm-hmm. And then all of a sudden, it's okay though. And so I think those are things that, if you want us to provide a sense of belonging and a co-curricular experience that is blending your high impact practices in class, I'm going to now use their language, and with our co-curricular, that's called a chip. Let us be at the table with you. And you got your hips, I got my C for your chips, and I'm going to help keep the butts in the seats. But if I don't know why they're stopping out, I can't help you. But if you actually give me a chance, how about we create prior to them coming to campus, just a quick basic needs assessment to figure out what impacted them. So that way, maybe the care team cannot be a care team in firefighting, but a care team in making sure we get them connected to the right resources coming in and we can actually care for them.
More proactively.
Just a little innovation, just a little.
Yeah. Anyone else want to add to that? I have a couple of thoughts myself. I think a lot of times, just having gone from the academic world where I started out my career to more of the business side, I do think that it still comes back down to the justify the why, right? And that's how you incorporate or sneak mental health into these the stakeholders more strategically. A lot of times you have to figure out what matters to the people in charge, right? And if dropout rates that are high are bad for business, that's where you start and you say, dropout rates are tied to poor mental health. If we can fix poor mental health, we can improve dropout rates, you look better, right? And it could be something as simple, obviously it's much more complicated than that, but that might be the starting point where we kind of figure out what's at stake. And it usually comes down to dollars and cents, or it comes down to risk and liability. And if you could solve for either one or both of those with your plan, then I think you could take things a long ways. We are 1 minute over. Any last minute things? Swapna, go ahead.
I know we're over, but
Yeah.
I want to add this. When we center our student voices, so whenever I'm getting frustrated with not getting buy-in from someone about something, centering those student voices, making sure that student leaders and student activists are sharing what it is that they need, what they're concerned about, what they're interested in, because that is a way that I think, at least at Michigan State University, I think that very vocal student presence and centering their needs has led to so much change in the last few years. So yes, it's dollars and cents, I know that, and student activism and student leaders and fostering that. So I just, that's what I wanted to add.
And the last piece I add to kind of center one of the questions in the group, we're talking about other specialized populations, graduate students, veterans, parents, LGBTQIA. It's just to make sure that when we're talking about this data, we're doing qualitative and quantitative surveys, doing user experience, town halls, doing different types of surveys and also conversations with these student populations, partnering with your student government associations, being very creative of how you solicit the information and the data to make sure that you're staying on top of newer trends, and also what is the student user experience in navigating this healthcare system on your campus.
Yeah. All right. So in the interest of time, I will wrap it up. I want to thank the three of you. You made my day, week, month, year, you name it. This was truly inspirational, well-informed. You were all incredibly talented experts in your field, very passionate in the work that you do, and we're very honored to have you lead this discussion. I know that there are a ton of questions that did not go answered. We will try to maybe collate them, send out some slides, and answer as many questions as we can. But I think if for those of you listening, if all you did this year was come to this talk, I feel like you gained a lot. So this is amazing. Great job. Thank you so much.